Hello everyone, good afternoon. Welcome to the second lecture of week 4 of the certificate course, that is Law and Alternative Sexualities. Today we have Dr. Kanchan Pavar for the session titled Homosexuality and Medicine. Dr. Kanchan Pavar is a primary care physician and public health consultant who is currently working with Mitra Clinic, Center for Transgender Health in Pune, a part of Project Accelerate, which is being implemented by YRG Care in India and is funded by the USAID. She is actively involved in state and national campaigns for patients' rights and accountability of the private health sector. She has previously worked as a medical technical officer in the Mukta project Pathfinder International, which was the part of the Avhan project for the prevention of HIV and AIDS in India, and which was funded by Bill and Melinda Gates Foundation. And she was responsible for technical supervision of targeted interventions involving MSM in Pune district and training of healthcare professionals on HIV and AIDS. So I will now request our guest speaker, Dr. Kanchan Pavar, to take over the session, and we all are looking forward to learn something new, more added to what yesterday our another speaker, Sylvester Merchant, has shared. Over to you, Dr. Kanchan Pavar. Dr. Kanchan, we are unable to hear you.
Okay. I forgot to unmute myself. Yeah. So thank you for that introduction. Hello?
Yes, we can hear you, Dr. Kanchan.
Okay, you can hear me? So thank you for that introduction. And I'm really excited to be here with you all. As Dr. Renu has mentioned, I am a doctor and I have been working with the LGBT community over some years now. And this talk is going to be essentially from my perspective as a practicing physician. And so let's start.
I'll share the PPT, Dr.
Yes,
Kanchan.
please. Yeah, thank you.
You're welcome. Is it visible? Can you see?
Can everybody else see? I
Can
can't see.
everyone see?
No, ma'am, it's not visible.
Yeah,
Okay,
it's
let me just check. Can you see now?
yeah.
Okay.
Could you make it full screen? Could you put
Yeah.
it on the
That's how it is coming. Just wait. Is it okay?
I don't know, is it visible to everyone? I would prefer to be on reading view if possible. Is that does that happen?
Can anyone tell me, is it visible to all of you?
Yes, it's visible.
Yes, ma'am.
Okay.
Okay.
It is visible, but please make it in presentation mode.
Yeah.
Yeah. So if you go down to the icon,
Slideshow. Okay.
Maybe it will work then.
That's what I... Just a minute. I don't know, for some reason it is just a minute. I think it is coming like this only for some reason.
Okay. Should we just proceed then in that case?
I think I'll just see how I can figure it out. Just a minute. I think you can start.
Okay. So, yes, today I would be talking on homosexuality and medicine. Essentially, my attempt through this session would be to explain about the medical aspects of or the medical concerns and what are we doing about them in terms of progress, medical progress, or in terms of actions to deal with them, and also what exactly medical care entails for the LGBTQI community. So in this session, next slide, please. So in this session, we will be next. Could we move to the next slide, please?
Is it? Mental health concerns?
No, it is contents.
Yeah.
So, but it's not moving past the first slide.
Is this the one?
No,
Contents?
yes, content,
Yeah.
but I don't see it moving past the first slide.
Oh. This is what the first slide.
This is the first slide. The second slide is some called contents. But it's correct me if I'm wrong. It's not moving past the first slide. It's not going to content.
Okay. Yeah, it's not.
Okay, so then should I?
Can you share? Just a minute.
Yeah. Okay, it's come. So in this session, we will be looking at the common health concerns of the LGBTQI community. We'll also look at what trans and homophobia in healthcare looks like. After that, I would like to talk about HIV and sexually transmitted infections, in brief, since this is something that has been always a point of concern with the community. After that, we'll take a look at what transgender health is all about and also about gender affirming healthcare. Next slide, please. So amongst the, I should start with mental health concerns, which is the third slide. Now, this has been covered in quite some depth by Sylvester yesterday, but I would still like to talk about it from a medical practitioner point of view. So a lot of clients who come to us from the community talk about social stigma, abuse, harassment. This is the next slide, mental health concerns.
Yeah.
It's not reflecting on the screen. Okay, fine. sorry. So, social stigma, abuse, harassment, bullying, neglect, rejection, or unfair treatment of the transgender and gender non-conforming community is very common. There's data and studies globally that show that this community has more than its fair share of mental health issues because of the discrimination and stigma that they face. And as a result, because of experiencing this from a very young age, it leads to repeated trauma. And this trauma results in long term physical and psychological effects. As a result, this community is at higher risk than the average population. And what we do tend to see very frequently is emotional and psychological abuse, including self harm, practices like cutting, which means that they cut their forearms or other body parts with a blade or with a knife or with serrated objects. So self harm is very common. We also see that because of societal stigma, because of the family members not accepting their gender identity or expression, they are often forced to leave home at a very young age and find themselves homeless or on the streets or without any sort of a social network or social support system. Um, which is why you see them coming in and often reporting physical violence while they get into, for example, if they're on the streets. The hijras always come, they always report about physical and sexual violence that happens to them. These incidents are very common. We've even had a staff member from our clinic being assaulted a couple of months ago, just for looking the way that they did. And so physical and sexual violence is common, which leads to subsequent post-traumatic stress disorders and substance misuse. Substance misuse, these are negative coping mechanisms to deal with a lot of stress in their life. Community members report use of alcohol, tobacco, gutka, weed, and drugs. And this starts at a very young age. So we do see young patients in their 20s and 30s suffering from long-term chronic side effects of alcohol or tobacco overconsumption. They have fatty livers, they have liver cirrhosis, which is a chronic condition of the liver, and or they come with submucous fibrosis, which happens because of chewing excessive tobacco or gutka. So a lot of substance misuse issues. Um, there are also patients who are diagnosed in the clinic with mental health problems, depression, anxiety, insomnia, suicidal thoughts, suicidal ideation, suicidal attempts. As Sylvester mentioned yesterday in their presentation, suicide rate amongst trans people is very high as compared to the average population. There are multiple data studies that are on these, but the sample size is small. We don't have a basic concrete data but from a first person point of view, from somebody who has interacted with these patients for a very long time, it is very common to come across patients and clients who have attempted suicide in their teens while trying to come to terms with their gender identity and while dealing with the discrimination or harassment from family and from other members. Um, on the rise, especially since the rise of social media over the past 5 to 6 years, I've also observed, or we have also observed that there's, this is anecdotal data, but I would like to share it. We are also seeing body dysmorphia and eating disorders on the rise. A lot of this, I feel, has to do with the rise of social media, the use of filters, and an unrealistic expectation to conform to gender stereotypes, the hyper feminine look, for example, or just generally the pressure that they have on themselves to appear a certain way or to conform to a certain stereotype. There are also quite a few stories on social media and Instagram of people who are transitioning, who are in drag, who are cross-dressing, and this has consequences because we see I, s- the younger cohort of I call them the millennials, uh, coming in with body dysmorphia and with eating disorders like bulimia and even anorexia. Um, One of the huge issues that we also see, and I also link this again to mental health problems, is the fact that because they are in constant conflict with themselves and with their family members, they have a lot of interpersonal problems with their peers and with their family members. And these problems can then lead, again, they just escalate the mental health issues and lead to further anxiety and depression. So lack of support and interpersonal issues and conflicts with family members, with their partners, also are a huge reason for development of mood disorders and other mental illnesses. Next slide. So the next slide, I would just like to talk in brief about the general health concerns. We have obviously the 30 plus cohort, which suffers from non-communicable diseases. These are not screened because patients are very reluctant to go to clinics and only go to clinics or are only diagnosed when the situation is out of control or the situation has already exacerbated to an extent that surgical intervention is required. So we have non-communicable diseases like diabetes mellitus, hypertension, heart disease, obesity, which are which are common. Then there are communicable diseases, including sexually transmitted infections, which also includes HIV. We also have hepatitis, which can be due to a variety of viruses. Most commonly are A, C, and B. Uh, Cancers are also because of we also see cancers, liver cancer due to hepatitis B. Um, there are also anal cancers, penile cancers, and throat cancers, which can happen due to HPV, which is a type of a virus. These cancers happen because of persistent and chronic infections and are sometimes diagnosed too late because the patient does not come in at an early stage. You also have submucous fibrosis and oral cancer or tongue cancer, as we say, because of tobacco and persistent chronic long-term tobacco and gutka use. Um, so 60 to 70% of the patients who come to our clinic come because of skin and hair related concerns. Um, Skin and hair related concerns, these are not just cosmetological concerns, though of course a large proportion of the population comes to us for cosmetological issues, which can be anything from skin lightening treatments to acne treatments, fungal infections, laser hair removal, male pattern balding, hair loss. These are issues actually that affect the transgender community or the gay community quite a bit. Again, this is not just the urge to conform externally, at least to a feminine look, but is also due to a lot of peer pressure. So yeah, we do see a lot of skin and hair related concerns. And lastly, about anal health, we do see patients with hemorrhoids, fissures. These are all complaints that come around because in the anal area, so hemorrhoids, fissures, or allergic proctitis, so an allergic infection of the anorectal area. Um, the incidence of hemorrhoids and fissures is the same in as in the general population, but what causes complications is the practice of anal sex. Because patients are having anal sex, hemorrhoids and fissures often get exacerbated and develop complications. So, because of that, this becomes an issue for which they have to seek medical help. Next slide. Okay. Now, I decided to mention about reproductive and fertility concerns as I have had now transgender patients coming and inquiring about the possibility of having biological children. Over the past decade, this was not even a discussion. It was simply an assumption that if you're transgender, you cannot have kids, that there is no possibility. And the only possibility in which you can have kids is to adopt them, whether adoption was legal or illegal. But I do know of patients who have adopted children. However, of late, again, because of exposure to what is happening in Western countries and the realization that same-sex couples, be they male or female, or even transgender people in partnerships are able to have biological children. Biological children. I have had patients coming to me and inquiring about this possibility in India. So, people in same sex relationships who aspire to have biological children have had few options in India till now. Now, even though surrogacy is an option, surrogacy is basically a procedure where you have the sperm of one partner, which can be used to fertilize a donated egg, which is then carried to term by a surrogate mother. This is an option, and there have been cases wherein even prior to I think 2013, when surrogacy was commercial surrogacy was going on in the country, Western couples used to come to India to have same-sex couples used to come to India for surrogacy. But now, since the Surrogacy Regulation Act 2021 has been passed, the act has does not it bans commercial surrogacy. It permits altruistic surrogacy only for Indian married couples, Indian origin married couples, and Indian single women who are widowed or divorcees. That too, I think, till a certain age. So there is no mention in the act of same-sex couples, of live-in couples, single parents, and the LGBT community. Thus, the act has been roundly panned by the LGBT community, saying that it's discriminatory in nature and it does not permit um, the LGBT community under the scope of Article 21 of the Constitution, which is the right to life and to personal liberty, and includes the right to motherhood and the right to reproductive autonomy. So, gender rights activists in India have actually criticized the act and pointed out that since it does not apply to same-sex couples, transgender individuals, and the LGBTQ community, it's discriminatory in nature and denies community members the chance to have a child of their own, a biological child of their own. Um, but in with patients who come to us for gender transition, we do mention that this is what is being done abroad. There are maybe some who want to consider that possibility and wish to know how it is done. So you have options where you can offer, where you can discuss with clients the possibility that they can preserve their sperm, um, or they can preserve if it's a male to if it's a male to female, then they can preserve their sperm cryogenically. And if it's a woman who is transitioning to male, then they can store their eggs prior to the gender transition processes, because once you start with hormone therapy and once you go through surgery, then you cannot do that anymore. So any discussion about fertility has to be had prior to gender transition. Next. So though this has been covered again briefly, I did hear it in yesterday's lecture by Sylvester. I would still like to discuss about what are the barriers to healthcare for members of the LGBT community. The next slide, please. No, it's barriers to healthcare. I think we skipped one. Yeah, thank you. So the barriers to healthcare, if you look at it, existing trans and homophobia and discrimination in many clinics and hospitals is the most important barrier, I think, to access to care for the TGNC community. And this homophobia can be overt, it can be covert. You see it in the way, for example, that not just the doctors, but other healthcare professionals, other healthcare workers in the hospital and clinic interact or engage with the patient, which is overtly, and also covertly, for example, by not specifying or not allowing people to access gender neutral bathrooms or to choose a room based on their chosen gender identity. So this, because of this, and this comes across all the time in communication with patients, that they hesitate to approach doctors, healthcare professionals. They know that they have problems, they want to be seen, but it is this fear, shame, guilt, anxiety about being treated in an inappropriate manner, about being treated insultingly, uncertainty about if the doctor is going to respect um, respect the confidentiality and the privacy of the patient. These are all reasons that are cited um, and have been also quoted in studies about being an important barrier, being a crucial barrier to access to care for the TGNC community. Now, which is why whenever we see patients or when we see patients, they've reached a stage where drastic action is required, unfortunately. A second reason is that the transgender community, and this is something that they have been talking about for a very long time actually, is that the transgender community has very unique health concerns. For example, it is not just about STI or HIV for them, but it's also about sexual health. It's about gender transition services, which can be through medications, which can be surgical, and they also require a whole multi-specialty team. You need an endocrinologist, a doctor who deals with hormones. You need a plastic surgeon or a cosmetic surgeon who can do the surgeries, the gender affirming surgeries. Then you require a psychologist and a psychiatrist, a primary care physician for after surgical care, and regular follow-ups. There's a whole multi-specialty team that is required to provide this kind of care, and that is something that is lacking. It's lacking in cities and more so in hospitals. I mean, in rural areas where there is absolutely no facility to cater to the needs, to the healthcare needs of the transgender population. So because of this, what happens is, even though they do come to us, there is always a loss to follow up. Um, the population is also, for example, migratory in nature. They go from place to place and therefore find it difficult to keep up or to follow up with a same same healthcare provider. And which is why their treatment is sporadic and it is not possible to for them to come in and see the doctor on a consistent regular basis. And this problem is very acute and very crucial in rural areas. Now, lack of competent and sensitive, informed physicians in clinical facilities, again, more so in in rural areas. This is one of the biggest challenges, that we do not have enough healthcare professionals and primary care physicians. I'm stressing them that because they are usually the first point of contact. We do not have, there's a severe dearth, or I would say, of professionals who are trained to deal with issues of the LGBTQI community. Um, Therefore, there is, because there are no such doctors, that is a huge barrier. There are financial barriers, which is crucial. There is, for example, lack of medical insurance, lack of stable income, a high cost of gender transition services or gender affirming hormone therapy. So these are financial barriers. And if you, what happens is because um, they find out about their identity and they decide to do something about it, or they are bullied so much at school, it is so obvious or so prevalent, that in the case histories that they are bullied in schools and find it so frustrating to deal with the harassment, with the constant ongoing harassment, that most of them leave school, they drop out. Dropping out of school after their 8th or 10th standard leads to then them being unemployable. And because they don't have the necessary educational skills to take up a stable job, they don't have stable income and have to resort to whatever money it is that they can gather by doing sex work or doing mangti or badhai. I'm talking about the hijra community. Um, there is also a great fear of disclosure. So that also results in being a barrier. And there are also socioeconomic barriers, which means that, again, as I said, education, transportation, and housing are huge issues for them to be able to access and make use of healthcare services. Out here, what, for example, I would like to say is also that not only is there trans or homophobia, uh, there is also HIV related discrimination and phobia. So, for example, we do have patients who are from the community and have tested positive, and therefore have to bear twice the brunt, not just of being somebody who is transgender or LGBTQI, but also being HIV positive. And the pressure, or this being another form of discrimination, becomes a huge reason for dropping out or not being able to access healthcare. So, for example, we had a patient who a young man around 20 years old, who came to us and was extremely distressed. Um, he had actually been admitted in a private hospital for surgery, hemorrhoid surgery, and he had to go in for all this pre-op tests, and the HIV test came out positive. This was in a rural area, and the moment that the test came out positive, the person was asked to leave because they said we do not perform surgery on HIV positive individuals. Uh, and when he talked about his healthcare rights, he was threatened about disclosure. And being coming from a small area, he was really concerned about the fact that his sexuality would be disclosed to his family or relations. And he had to take a decision then to come to Pune. Um, which he could manage almost 4 or 5 months later, by which time his condition had deteriorated quite a bit. So this is something, what I'm talking about is HIV-related discrimination and coupled with transphobia or homophobia. So in healthcare, talking from a medical point of view or a professional health point, what is it that contributes to this in healthcare? Could we have the next slide, please? Right. A lot of it has to do with prejudice, societal stigma about the community. It has also to do with a concern or fear about losing other patients. Say, for example, there are some people who walk in openly transgender. Everybody is immediately uncomfortable and doctors worry about that impact on their other patients or on their professional reputation. So that is another reason why we see that. Many healthcare professionals are actually uninformed about transgender and gender non-conforming healthcare because of lack of clinical training, because of lack of exposure and sensitization at both the undergraduate level and the postgraduate level. Sylvester did talk about this yesterday. But I would like to talk about something about, so they lack the knowledge and they lack the comfort level to engage with the community. Now, why is comfort level so important? Comfort level is important because you require a certain rapport with your patient, and this rapport only comes if you have a non-judgmental attitude, you have a neutral empathetic tone while communicating with the patients, and communication both verbal and non-verbal. It is also important for the doctor to not feel awkward, for the doctor to display comfort and ease while discussing about sexual health, while talking about or taking the history about sexual intercourse, what kind of sexual acts are being done, whether the person or the patient practices insertive or receptive intercourse, all of the number of partners, etc. um, Doctors are generally, I would not say not just with the community, doctors are generally uncomfortable talking about these issues. These are skills and competencies that are not, what do I say, that are not discussed or that are not addressed in medical colleges. So doctors come out and find themselves hampered. They find themselves unable to discuss and counsel patients appropriately. And they also feel very unsure about how to talk to such a person because they themselves lack a lot of understanding about gender identity, about sexual orientation, and are frequently confused between the two. So, for example, if a patient will label himself as a hijra, the doctor assumes that the person is a transgender, but that is not the case. Maybe the person is a homosexual or a bisexual, but is labeled as a hijra by peers or by family members because they see him having sex with another man. And that's what they are called in a cultural context in India. But doctors do not are not aware to be able to probe about these issues and correct their understanding and the patient's understanding about his or her gender identity. So that is the reason why also you see transphobia and homophobia in healthcare. Next slide, please. So I thought it would be helpful to just see what kind of examples can one see in healthcare settings. Some examples of, for example, just refusing to admit or treat TGNC patients because of their sexuality or gender orientation, or overcharging them, which we see very frequently across the rural and urban divide, that they are forced to pay a premium because of their orientation or gender identity. Um, Forcing TGNC patients to have intrusive and unnecessary physical examinations when the condition does not demand it. If a patient has come to you for a heart-related issue or for diabetes, there is no need to ask the patient embarrassing questions or force the patient to undergo intrusive or unnecessary physical examinations. Refusing to provide healthcare services to TGNC patients, which are routinely provided to other patients. So, say for example, if a patient requires IPD admission, refusing that person IPD admission on grounds of his or her gender identity is an example. Refusal to treat TGNC patients according to their gender identity. If a patient comes to you and identifies as she or her and wants to be addressed accordingly in as a woman, uh, and the doctors refuse to do so because the patient is not dressed in a feminine manner, that is also transphobia. a very common example that happens. Not providing them access to restrooms as per their chosen gender identity, then refusing to provide counseling or services, referral services, or support services because of their orientation, requiring people, transgender community or the LGBTQ community members to participate in conversion therapy for the purpose of changing gender identity, which a lot of our patients are forced to undergo. Even now, after the Supreme Court has declared that conversion therapy, and the Indian Psychiatric Association has also declared that homosexuality is not a crime per se, and it is criminal to practice conversion therapy, but it is still happening in real life. So, and attempting to, of course, harass or intimidate or interfere with transgender, with TGNC patients who and their ability to exercise their patients' rights or their health rights. Next. So now I would like to just talk about sexually transmitted infections because uh, the MSM umbrella. I mean, Sylvie talked about this thing, about yesterday about MSMs, men who have sex with men. This is an umbrella term that's used for all men, regardless of how they identify or how they express themselves. For men having sex with men. Now, this can be situational, this can be a one off, for example, in prisons, or it can happen on a consistent basis. But they are considered to be at high risk for sexually transmitted infections. Why? Because one, uh, there are high chances that they practice anal intercourse without condoms, and unprotected sexual intercourse does uh, make you more likely to get or to contract infections. So STIs, what are sexually transmitted infections? These are a group of communicable diseases that are transmitted predominantly through sexual contact with an infected person, right? And what kind of sexual contact are we talking about? The sexual contact can be anal, it can be vaginal, it can be oral. So any kind of sexual contact, anal, vaginal, very rarely oral, or genital skin to skin contact. That kind of contact can transmit STIs. We have what are the different kind of STIs? What are the most commonly prevalent STIs? HIV, of course, comes on top because of the consequences of the infection. So this is a viral infection, which, if untreated, can lead to AIDS, and AIDS is a fatal condition. So HIV is a STI. Then you also have syphilis. Syphilis is a bacterial infection. It causes long-term serious complications of the heart and nervous system if it is not treated immediately. So if caught in the primary stage or even in the secondary stage and treated appropriately and monitored thereafter, syphilis can be completely cured, as I said. But if it is not treated, it can lead to long-term chronic and possibly also fatal complications of the heart and the nervous system. Then other common infections are gonorrhea and chlamydia. These are both bacterial infections that cause urethral discharge, that is a type of discharge through the penis, and can cause fertility complications. Fertility complications are quite critical because a lot of the MSM community is bisexual or are married, have partners, have children. So there is a chance that they also pass on these infections to their partners. Um, fertility complications are important for gonorrhea and chlamydia. These are bacterial infections. Then you have hepatitis A and B, which are again viral infections which can cause permanent or chronic damage to the liver. You have something called as HPV, which is human papilloma virus. This is a viral infection that can cause genital warts and can also lead to certain cancers. It is important to keep in mind that all STIs are completely curable except the viral STIs like HIV, hepatitis, herpes genitalis, and HPV. These are viral STIs. So, though the person might not have the symptoms, they become lifelong carriers of these infections. So, they have asymptomatic phases and they would have a symptomatic phase, as in the example of, say, herpes genitalis. But this is then an infection that you become a lifetime carrier of. Now, because the prevalence of STIs is around 5 to 6% amongst the adult population, um, and in TIs it is even a bit more, around 8%. This would mean that there would be around 33 million STI episodes. That is a NACO estimate from 2017. This is why MSMs or members of the LGBTQI community are advised, or people who indulge in high risk activities are advised to screen themselves regularly for sexually transmitted infections. That means that you get tested for HIV every 3 months and for syphilis every 6 months. And if you have symptoms, you should also then get yourself screened for other sexually transmitted infections as well, based on the advice of your doctor. Next. So coming to HIV and AIDS. Um HIV, as I said, is a viral infection, but there is a very crucial difference, which is that HIV is different and AIDS is different. HIV is the virus that causes the infection. It is a virus that attacks the body's immune system. Specifically, it attacks a particular cell called a particular white blood cell, which is responsible for immunity, and the cell is called as a CD4 helper cell or a T cell. Now, it attacks the cell, and slowly, as over time, if it is not treated, the number of cells in the human body go down to an extent where the body's immune system is not able to fight or fend against even normal infections or normal pathogens. So basically, that is the difference between HIV and AIDS. AIDS is the end stage of the disease, it's the last stage. It's a cluster of conditions that develop in the human body when the number of CD4 cells is so depleted that the body cannot fight enough infections, and it therefore develops a range of life threatening and possibly even fatal infections like tuberculosis, pneumonia, chronic diarrhea, fungal infections, and death that happens is because of AIDS. It is important to understand that a person can be HIV positive and be healthy all his life, or his or her life, if they take the appropriate medication and look after themselves. A person who has HIV does not automatically should not automatically be labeled as a person having AIDS. These are two different things. Next. So out here, I would just like to very briefly explain the natural history of HIV, just so that this point is clear for our understanding. So in the blue line, what you have is your number of cells, and the helper T cells, as I said, the CD4 cells, and the red line essentially means the number of viruses in your body. With the primary infection is like a flu. You will see it will happen between a month or 4 to 6 weeks after the infection or after exposure. And there is an increase in the viral load, and there is a decrease in the CD4 count because of the primary infection. This is the actual infection that happens. Most people do not even realize that they've been infected because it expresses as a flu. Now, the point or this period from which the virus enters the host, and you see that detectable levels of antibodies appear, it's called as a window period or an acute infection phase. So the window period can last from 3 weeks to 3 months. During this time, the individual is infected. The individual is also infectious to other individuals via sexual contact, unprotected sexual contact, or blood donation. But antibody levels are not detected during this phase of infection. So the person actually, if the person gets tested during the window period, the person can test negative. There are, of course, extremely sensitive tests, ELISA, Western blot, that can work during this time, but normally in the window period, tests that are done test negative, and the time frame is from 3 weeks to 3 months. Now, after this, if you see, you will see the red line stabilizing, uh, and the CD4 cells um, declining very gradually over a period of time. Now, this can be from 1 year to 10 to 15 years. As long as the CD4 count of your body in your body is stable, above a certain level, the body can deal with infections. But as the count gradually decreases, the level of viruses in your body increases, and because of which you start seeing different infections, opportunistic infections coming up. So the range is, there is a clinically latent period that can last from 1 year to six or even 10 years or even 15 years. But after that, one starts to see a variety of opportunistic infections. Tuberculosis is the most common opportunistic infection. You also have sores in the mouth and tongue. You have candidiasis, which is a fungal infection of the GI tract starting from the mouth, different kinds of pneumonias, bacterial pneumonias. So death that happens essentially happens because of these end stage opportunistic infections. This is the natural history if the person is not treated or does not take treatment. Next slide. Yeah. As I just mentioned, opportunistic infections, the most common are pulmonary tuberculosis. You have something called as herpes zoster, which is a viral outbreak, bacterial pneumonia, oral candidiasis, fungal infection of the mouth. You have ulcers, chronic persistent ulcers that do not respond to treatment in the mouth, on the esophagus, in the esophagus, which is the food tract, genital ulcers. We also have chronic diarrheas, uh, cryptococcal meningitis, pneumocystis carinii, which is again a different kind of pneumonia. So these are opportunistic infections that ultimately happen in the stage of AIDS and result in the person's death. Next slide. While this has been covered yesterday, so I will not repeat this again. But I would just like to mention that with a HIV prevalence of around 0.26% in the adult population, so India approximately has 2.1 million people living with HIV. What we have in India is what we call as a label as a concentrated epidemic, which means that the infection or HIV prevalence is concentrated amongst key populations, which are called also high risk groups. Now, who have unprotected sexual intercourse with multiple partners, or who use drugs or who inject drugs. Now, these populations, for example, include female sex workers, men who have sex with men, as I said, transgenders, IDU users, long haul truck drivers, and migrants. The National AIDS Control Program that started in India in 1992 essentially took a very focused approach and came up with targeted intervention programs over the next two phases. These targeted intervention programs aimed at offering prevention and care services to high-risk populations. Now, how did they do that? They provided them information. So there were behavioral change campaigns that were launched, focusing on these groups, trying to encourage them to use safer sex practices, to give them the means and the skills to minimize HIV transmission and to improve their access to care and support services. So targeted interventions is essentially what I started working with, and this is how I was introduced to the entire NSCP program from 2005 onwards. So we still have targeted intervention programs, and if you look at the 2014, 2015 integrated biosurveillance and behavioral surveillance, then HIV prevalence amongst the MSM is around 4.2%, and amongst the transgenders, it's around 7.5%. And the overall incidence of or prevalence of the overall prevalence of HIV in the high risk populations, it varies between 2.2 to almost 9%, and it also varies state by state. So targeted intervention programs are still continuing in all major states of in all states across India, and are implemented now through community-based organizations, CBOs as we call them, and provide a spectrum of services that aim on minimizing HIV, the spread of HIV infections in these clusters. Next slide. Yeah. So in management of HIV, what is happening actually is I'm talking only about the government approach. Obviously, there are also doctors in the private sector who are taking care of HIV positive PLHAs, I mean. But here I would just like to talk about the National AIDS Control Program and the services that are provided through it, because it addresses the bulk of PLHA in India. In management of HIV, essentially what NACO has done is it's adopted a test or treat policy towards PLHIV, and as of it has established referral and linkage mechanisms to connect PLHIV as soon as they're diagnosed to ART centers. ART centers are centers that offer antiretroviral therapy, which is a combination of drugs. It's called HAART, HAART, highly active antiretroviral therapy. So this is a combination of 3 drugs that are given to PLHAs to be taken on a daily basis, and are given free of charge through these ART centers. So we have nodal ART centers and link ART centers through which everybody who tests PLHA are offered antiretroviral therapy. The care and support centers also provide support to PLHIV on ART, such as regular monitoring of CD4, which is the cell that is an indicator of the level of immunity in your body, and the viral load. Depending on that, they're also screened for opportunistic infections. They are given prophylactic treatment to prevent opportunistic infections, and are also offered nutritional support. There's also an HIV Tb Collaborative Initiative in which patients for TB and patients with HIV are screened on a regular basis for tuberculosis, for opportunistic infections and for HIV. So patients with TB are tested for HIV, and vice versa. Patients with HIV are regularly screened for tuberculosis. And other opportunistic infections. So doctors at ART centers also screen PLHAs for other opportunistic infections, including TB, TB pneumonia, herpes zoster, oral candidiasis, oral ulcers, diarrheas, etc. So if you look at it, around 1.5 million PLHIV were alive by 2017. They were accessing ART through more than 531 ART centers, and 1,108 link ART centers. So the NACO also provides a second and third line treatment. Say, for example, the first line regimen for ART does not work with the patient, then at certain centers, NACO also offers free second and third line regimens as well. Next. I'm going to cover this very briefly because Dr. Seema from NARI will be talking about it in detail in her lecture tomorrow, I assume. So the mainstay for prevention of HIV and other STIs in the National AIDS Control Program are through its integrated testing and counseling services, so the ICTCs. Now, ICTCs are different from regular labs, which just test for HIV and then give you the results. ICTCs actually have counseling services. So they have pre-test counseling and post-test counseling in which the counselor focuses on risky behaviors such as unsafe sex or needle sharing and offers strategies and mechanisms, means and skills to mitigate these risky behaviors. They also offer linkages through which they can be linked, high-risk groups can be linked to targeted interventions. And in case they come out positive, then they are counseled appropriately and linked immediately to the closest or the most convenient ART center. So integrated counseling and testing ICTCs are basically the mainstay of HIV prevention and screening. Over the past, from 2012 onwards till now, which is the extended phase of NSCP 4, services have really been ramped up. The number of ICTCs have been ramped up through mainstreaming them, through creating, for example, more than 22,000 ICTCs, including tie-ups with the private sector. So in a preferred PPP mode, public-private partnership. So we have almost 4,000 in the private sector. And so there are no places actually where an ICTC is not available for free HIV testing. Also, there are different ways of being tested for HIV. So there's something called as community-based screening, which is done on a using a kit, which is very simple. Even peer educators and outreach workers can do this testing in the field. It comes like a pregnancy kit and just needs a drop of blood. If positive, then patients or people are referred to ICTCs for confirmatory tests, which are done through ELISA and Western blot. We also have HIV self-testing, which has come up very recently and involves you can do the HIV self-test at home by using your saliva. And this is also hoping to increase the number of people who voluntarily test themselves for HIV. Then we also have for people who have the right history, as in who give a history of, say, frequent intercourse, unprotected intercourse, multiple partners, or having a partner who is HIV positive. These people can be offered pre-exposure prophylaxis, so PrEP regimens, which is also a combination of a drug that can be taken daily and reduces your chances or reduces a person's chances of getting HIV. So PrEP regimens are also being now offered through ICTCs and so through ARTs, I'm sorry. STI and RTI services. Other than HIV, there are also STI and other reproductive tract infections which need to be screened regularly because having one increases the chances of getting HIV. So there are STI or RTI designated clinics along with preferred providers. Preferred providers are private doctors who have been linked with targeted interventions and screen patients for STIs on a regular 3-monthly basis. And treat them using a special approach that is called as a syndromic management approach. In syndromic management, you give the person a single kit which treats the patient for all possible causes causing that particular symptom. So say if the person has urethral discharge, which is discharged through the penis, the person is treated for chlamydia and gonorrhea. Both infections cause the same symptoms. So using a syndromic case management approach, high-risk groups are treated for, again, free of charge through the DSRCs and through preferred providers. And there are also IEC campaigns to educate vulnerable populations about HIV and STI prevention and treatment. Next. Coming to the transgender community in India, transgender is an umbrella term, as Sylvester explained yesterday. It covers hijras, It covers eunuchs or kothis, aravanis, jogappas, shiv shaktis. All of these are essentially cultural or even professional identities, even religious identities or religious groups or sects. But the transgender umbrella covers all of them. It covers trans men as well as trans women who do not or are not a part of any of these sects but identify differently from their assigned gender. It also includes intersex persons. Intersex persons are persons born with a body type which mixes or blends um, what is the standard male and standard female type. So, for example, the mixing can happen at the level of the sex chromosomes, XY and XX. Or it can also be expressed in the form of gonads, I mean, the genital organs, the sexual organs, ovaries, testes, ovotestes, or external genitalia, or internal reproductive anatomy, or a combination of those. So these persons are labeled as intersex and are also included under the transgender umbrella. Please do keep in mind that transgender refers to gender identity and gender expression, but it has nothing to do with sexual orientation. Transgender people can be heterosexual, they can be homosexual, bisexual, asexual. So one does not mean the other. This is a confusion that a lot of people make. I used to make it as well. So I would like to clarify it again that transgender refers to gender identity and gender expression. It does not have anything to do with sexual orientation. Next. Now coming to gender affirming care. I really like this definition because it's a very holistic definition. It's a comprehensive definition. It's healthcare that holistically attends to transgender people's physical, mental, and social health needs and their well being while respectfully affirming their gender identity. So essentially, it can mean a single or a combination of a number of social, psychological, behavioral, medical, surgical interventions that are designed to support and affirm an individual's gender identity. Now, what does gender affirming care include? Next slide, please. Right. So gender affirming care essentially means gender dysphoria certification. It talks about gender affirming hormone treatment, which can be female to male or male to female, including counseling, treatment, monitoring, and follow up. And it can mean it includes gender affirming surgery, GAS for short, and gender affirming therapy, psychotherapy that focuses on affirming a person's or a patient's gender identity and does not try to repair or correct it. So this is a spectrum of gender affirming care that we are talking about. Coming to the first one, which is gender dysphoria certification. Next slide. Now, gender dysphoria diagnosis. Next slide, please. Right. Now, this has been a huge controversial issue for decades. Why? There are many gender rights activists, many trans persons who question why gender dysphoria should be addressed as a mental disorder, because this is basically what we're talking about, medicalization of the transgender identity or gender identity related disorders. Why? Because if you look at gender dysphoria, this is essentially a definition that is mentioned in the Diagnostic and Statistical Manual of Mental Disorders. So there is a way that we use to classify this disorder, and it is called as DSM. So in DSM-5, if you look at gender identity disorder code, it is 302.85. So essentially, it says that this is gender non-conformity is not a mental disorder, but the physical stress and the mental stress that the gender variance induces in the patient. The dysphoria, the distress that is caused by the dysphoria is essentially the problem, and which is why it has been included in the DSMB. What a lot of gender right activists say is that it should not be included in the DSMB at all, DSM-5. It should actually be classified as an endocrinological disorder, a disorder of the hormones. Um, so I would like to point that out. This has happened in the other system of classification, which is the International Statistical Classification of Diseases and Related Health Problems. So the short term for that is ICD. The ICD is maintained by the WHO. Now this is a document that provides standardized data and vocabulary to diagnose and monitor health problems around the world. The updated version, the latest version, which is ICD 11, has put gender dysphoria into the diagnosis code of Z77.0, which means it has essentially redefined gender identity health and replaced the diagnostic category of gender identity disorder with gender incongruence of adolescence and adulthood. Thus, what ICD has done is it's broadly moved gender incongruence from the mental and behavioral disorders category and has put it into a new category or a new chapter, which is conditions related to sexual health. This reflects evidence basically that trans related and gender diverse conditions or identities, these are not conditions of mental health or ill health, and classifying them as a mental disorder um, can stigmatize the community more, can cause enormous frustration to the community. I also have patients who come to me and say that, why is it that a cisgender heterosexual woman does not have to go to a psychiatrist for certificates that she is a cisgender and a heterosexual person, but I have to go to a psychiatrist and spend 10,000 rupees to get this certificate that claims that I have gender identity um, dysphoria or gender identity dysphoria, gender dysphoria. So I see this as a progressive step. The ICD has already moved gender incongruence to a separate category in itself and removed it from the category of mental health disorder or mental disorders. In the DSMB-5, these are all classifications that are used in US but are also now used in India. DSMB-5 still puts gender dysphoria in the disorder code, in the mental disorders code. So this is the controversy regarding gender dysphoria diagnosis. As a doctor, I would say that I understand the point that gender right activists or even trans persons try to make when they are saying, why do we have to have this diagnosis? And why is it classified as a mental disorder? At the same time, having the certificate enables the person to seek healthcare, enables the person to seek gender transition services, and ultimately also claim for a transgender certificate in India. So as of now in India, there's no way around it. Gender identity, gender dysphoria diagnosis is given by psychiatrists, issued by 2 psychiatrists after consultations and a psychologist. Next one. Next slide, please.
Can you see, Dr. Kanchan, gender dysphoria diagnostic criteria?
Yes. So, no, I just wanted to go to the previous, no, just a second. Yeah. So gender dysphoria what are the diagnostic criteria? They explicitly state that the person has to display the presence of at least 2 or more of the following points uh, over a period of 6 months or longer. Our experience is that people display this for years over end, starting from childhood, but the minimum is 6 months. The first point is a marked incongruence between one's expressed or experienced or expressed gender and primary or secondary sex characteristics. A second is a strong desire to be rid of one's primary or secondary sex characteristic. This can mean breasts in the case of women. This can mean a penis, testes in the case of men. So a strong desire to be rid of these characteristics because of a marked incongruence with one's experienced or expressed gender. In young adolescents, it can mean a desire to prevent the development of the anticipated secondary sexual sex characteristics. Next slide. Then there is a strong desire for the primary or secondary sex characteristics of the other gender or of the chosen gender. There is also a very strong desire to be of the other gender or some other alternative gender which is different from one's assigned gender. How is this desire expressed? Does the person wear the clothing of the chosen gender or of the felt gender? Does the person cross dress, so to say? What is it exactly that the person is doing or expressing this desire for? There is a strong desire to be treated as. Hello? This is the next slide, yeah. There is a strong desire to be treated as the other gender or some other alternative gender different from one's assigned gender. And there is a strong conviction that one has the typical feelings and reactions of the other gender or some other gender which is different from the person's assigned gender. So the assigned gender is the gender that you are assigned at birth. What you feel, the gender that you identify with is the gender that you um, feel like identifying with. If there is a marked incongruence over 6 months, if there is a very strong desire, if the person reports physical or even emotional distress, a very strong desire to remove or be rid of secondary sex characteristics, the psychiatrist then issues a certificate of gender dysphoria. Now, this can happen in one consultation or it can happen in 5 to 6 consultations. It depends on the psychiatrist and the evaluation. If you look at the private market, these evaluations sometimes can cost between 6 to even 10,000 rupees, depending on the number of consultations with the psychiatrist. And which is why a lot of patients actually, or clients, get very frustrated that they have to prove uh, their gender identity to medical professionals or to psychiatrists. There is also a psychological assessment that is done using a Rorschach test mostly. And together with the 2 psychiatrists and the 1 psychologist, a certificate of gender dysphoria is issued, based on which then the person can proceed for gender affirmative treatment. Next slide. So coming to gender affirming hormone therapy. What is the objective? The objective is to align the external characteristics of an individual with their gender identity. So as I said, GD certification is required prior to the process. Once we have the the GD certificate, there is counseling of the patient that is done. The counseling means we explain to the patient about the process of the hormone therapy, the side effects, the expected effects. It's very important to adjust their expectations because sometimes they have completely unrealistic expectations. So we have to also explain the expected outcomes of the treatment. And after informed consent and baseline screening investigations, we can start with hormone therapy. Now, in India, you have feminizing hormone therapy, which is given to people who are transitioning from male to female. In feminizing hormone therapy, you give them hormonal tablets like estradiol, for example, and androgen blockers. These raise the level of female hormones in the body and decrease or suppress the level of male hormones in the body. We can also give injections, injection leuprolide, which is again given on a case to case basis. Not everybody needs it. So this is feminizing hormone therapy. one starts seeing effects from starting from 3 months to going on to 18 to 24 months. So, feminizing hormone therapy is can be taken till the age of 45 and requires regular monitoring every 3 and 6 months, and then annually for assessment of hormone levels. Masculinizing hormone therapy is offered to trans men, as in individuals who are transitioning from female to male. Abroad, one has patches, but in India, what is given most commonly is injection. It's a depot injection. So once every 2 or 3 weeks of a hormone, of the male hormone called as testosterone. Effects, as I said, start to be noticed from starting from the third month after treatment and continue to be observed over the next 3 to 4 to even 5 years. Um, the reason why we take informed consent for gender affirming hormone therapy is because some of the effects of the hormones are irreversible. Um, your reproductive ability, which means your egg production or your semen or the sperm production, the semen production goes down. And though there are people who have tried to, regain reproductive ability afterwards, it's compromised in quite a few cases. So this goes down, and feminization of the change of the voice, for example, is permanent. That happens because of testosterone and does not change or cannot be changed. So it's very important to counsel the patient. So far, a majority of patients who come to us, a majority of transgender individuals actually take medications over the counter. There is no counseling. There is no GD certification. They do not even see a therapist. They consult their friends. They consult maybe a nearby doctor to whom the friends are going, or they see the tablets that the friends are taking and say, okay, let me just try these injections and let me try these tablets. But it is important to understand that you might not have the same effects on taking the same medications, and that the doses have to be titrated extremely carefully depending on your baseline screening investigations after ruling out risk factors. So far, hormone therapy that has happened in transgender individuals, a very small percentage actually takes it as prescribed after GD certification from an endocrinologist. Majority of them buy medicines over the counter, take tablets unsupervised, and often land up in complications because of that. Next. Right. Now, what is normally advised is that the patient should take gender affirming hormone therapy, so should take medication, should live in the chosen gender, first of all, for at least 6 months to 1 year to feel comfortable with it. Start hormone therapy, stay on hormone therapy for at least a year, see how the body changes, feel comfortable with the changing body. We call it like a second puberty. When you start your hormone therapy, you're essentially going through a second puberty. So there are a lot of mental changes, emotional changes, irritability, aggression, depression, loss of libido. And so we ask or encourage patients to get adjusted to hormonal dosages, to get adjusted or to familiarize themselves with their changing bodies, and then consider then consider treatment, surgery. In real life, what happens is most transgender patients who come to us, who are members of the Hijra community, for example, come to us after having done their emasculation, which is called as nirvani in their language or in their terminology. So they come to us and they've already undergone um, gender affirming implants, surgery, like, breast implantation, or they've had emasculation or penectomies and orchidectomies. So we have to then start the hormonal therapy after counseling, but understanding that they have already taken the first steps towards gender affirming treatment or healthcare services. Most of the time, these surgeries happen, again, they're conducted with quacks, or maybe they are conducted in centers, but without the right GD certification, without appropriate post-surgical care. Patients are ill-informed about, for example, ill-informed about the side effects of, or the after effects of the surgery and what can result after the surgery. Um, so therefore, we see a lot of post-surgical complications also in the transgender community. Ideally done if you're looking at gender affirming surgery. Now, this is a spectrum of surgeries, and not necessary that everybody who takes who feels like they are transgender takes hormone treatment. Not necessary that they opt for gender affirming surgery. It's a spectrum, as I said, and there are many transgender individuals who are comfortable being as they are and do not feel the need to take hormone treatments or go for surgery. There are some who are 100% committed to transitioning to the whole gender transition process, and therefore opt for all the options. They go for hormone treatments and they go for gender affirming surgery. So when you're talking about male to female surgeries, I mean male to female transition, what we call as top surgery essentially means breast augmentation using silicone or saline implants. um, there is also bottom surgery, which is penectomy or orchectomy. Penectomy is removal of the penis. You can also refer to it as emasculation. Um, Transgenders now prefer not to use the term castration because castration implies forcible penectomy, as in, without consent. Whereas this is very much a voluntary penectomy. So uh, it's better to call it as penectomy or emasculation. Um, so bottom surgeries are penectomies and orchectomies. Orchectomy is essentially removal of the testes. There is feminizing genitoplasty, which means a construction of a neovagina. This can be done using the skin of the skin and tissues of the penis and scrotal skin. They essentially reverse the skin and create a neovagina out of it, which is then inserted inside. This is a functional vagina, and it is possible to have sexual intercourse. It is possible to have sexual pleasure uh, with this vagina. So not everybody opts for the vaginoplasties because they are very expensive. They go in the figure of 4 to 6 lakhs depending on the surgeon. And most of them, the transgenders that we see, opt for an external vaginoplasty, so to say, where they have a external vagina which looks like one, but not the actual vaginal canal. Um, Other than the bottom and the top surgery, there are a series of facial feminizing surgeries because hormone therapy is essentially going to change your body, but to not that extent because testosterone has already shaped the contours of your face. So it cannot affect the bones. The bones do not change. So many a time, transgenders opt for facial feminizing surgeries. This can mean, for example, shaving the Adam's apple, going in for a nose job to have a more feminine nose, reshaping of the jaw, lip fillers, the bro model like jawline and bro reshaping. So the list is endless, but most surgeries are quite expensive and require financial resources that a majority of our community does not have. Which is a source of great frustration and despair to them. The fact that they desperately want to undergo the surgery so that their external self matches their internal self, but they do not have the funds to opt for this surgery in the private health sector. So all these surgeries can go anytime, anything between say 70,000 for a penectomy or a 1 to 1.5 lakhs for breast augmentation. If you're talking about genitoplasty, it goes between 3 to 6 lakhs. Facial feminizing procedures again cost anything between 1 to 5 lakhs. This is a lot of money. And so there are very few people who are able to opt for it. But there is a greater realization amongst the community that that these surgeries are available for a cost, thanks to the advent of social media influencers who chronicle their gender transition stories on their Insta channels. Coming to male transition. So a female person assigned a female sex assigned at birth transitioning to male, they have top surgery, which is essentially breast reduction, which is performed through a procedure called as mastectomy, and gives the patient a masculine chest. There is also bottom surgery, which is of two different types. A bottom surgery consists of hysterectomy and oophorectomy. Hysterectomy is the surgical removal of the uterus. Oophorectomy is the surgical removal of the ovaries. As I said again, um, the external genitalia, the surgery that is called as a metoidioplasty, a phalloplasty, and scrotoplasty. So these are surgeries that essentially use skin grafts and use the available clitoral tissue, for example, to construct a penis and a scrotum. The success rate when it comes to surgeries in male to female is not so good. We do not see so many trans men who have opted for the metoidioplasty or phalloplasty. It is possible to have sexual intercourse using the penis, using a penile prosthesis. However, we do have patients who who opt for a penis, like a penile reconstruction, so to say, a metoidioplasty and a phalloplasty, mainly because they wish to urinate standing like men. So that is a very important thing for them. And so these surgeries are then carried out by plastic and cosmetic surgeons and require considerable post-surgical care. Yeah. So this is gender affirming surgery. Next. I would like to end my presentation by acknowledging that there is a lot that needs to be done about transgender and homosexual health, LGBTQI healthcare in India. It is thanks to the tireless efforts of many transgender activists over the past 2 decades, who have consistently advocated for the fact that transgender people require more, and the LGBT community, for example, or MSMs for that matter, should not just be regarded as a pool for HIV and STI, should not just be regarded as high-risk populations to be only screened for HIV and STI, but that they have a plethora of mental health issues and of gender transition issues that should be addressed by the government, thereby giving them the right to live their life with integrity and in confirmation of their chosen gender. So there have been a few steps, with Section 377 in 2018 being lifted, for example. Post that, of course, the government, we do see a lot of engagement with the government regarding LGBTQIA health. In October 2021, the government announced, for example, that the PMGY, the Pradhan Mantri Jan Arogya Yojana, its health insurance scheme, would offer healthcare coverage to transgender people and support sex change operations as a part of its revised health benefits package 2.2, as a part of its new scheme, which is which provides support for marginalized individuals for livelihood and enterprise. So the scheme is called SMILE, and under which the government has assured transgender individuals that their need for gender affirming hormone treatment and surgeries would be taken care of under the Jan Arogya PMJY scheme. So we have yet to see that happen in Translate, which just been announced. So we expect, that it will take a couple of months for the government to line up the resources and the necessary infrastructure to be able to provide trans-friendly, sensitive or trans-sensitive services in government hospitals. But there are discussions towards this happening. We are hearing about tertiary care hospitals in places like Pune for already, agreeing to have a transgender ward or a ward for transgender people. We have NGOs like Sanghat and ATHI, which is the All India Transgender Health Association. They have started initiatives for sensitizing healthcare professionals, for sensitizing doctors, and talking to them about trans affirmative healthcare services, including the fact that they are coming up with a list of core competencies for healthcare professionals. There's been a lot of criticism about the fact that doctors are not sensitized at the UG and PG level about LGBTQI health. The National Medical Commission actually recognized this and post in October 2021 after the Madras High Court decision, which stated that there was queerphobic material in MBBS textbooks. Um, the National Medical Commission, which is responsible for regulating medical education in India, has released an advisory regarding LGBTQI community, saying that concerned authorities should amend the information and remove or delete discriminatory references to LGBTQ community in medical textbooks. Of course, it's a very small step, and they have left the onus of this changes on the concerned authorities. So we do not know actually if the publishers and the medical colleges will actually take this up, but it remains to us to advocate for this consistently so that even doctors who provide trans affirmative services doctors are taught to provide trans affirmative services right from their UG years. So times are changing. I do see transformative policies coming into action now over the past 2 years, and which is why I'm sitting today in a transgender health clinic, which supports or which aims to provide trans affirmative services to the transgender community in Pune and in Maharashtra. So thank you for listening to me so patiently. It's been a very long monologue. I'm looking forward to your questions, and yeah.
Thank you very much, Dr. Kanchan Pavar. Now the session is open for questions and discussion. Okay, Ishwari, would you like to ask a question?
Yes, ma'am.
Please go
Uh,
ahead.
I had a question that the recent law on the Transgender Protection of Rights Act, which
Hmm.
states that it can provide us the district magistrate can give a certificate. So we see that many people have been criticizing that it does not actually honor the right of self-identification. So, in that balance, why is there such a tussle between the medical, the people belonging to the medical field, wherein they insist on the certificate, or our codes are not changed, and why the transgenders at the same time are, focusing more on self-identification when, the process can be done even after the certificate by the doctors are given.
So, coming from a medical point of view, it is extremely important for us, especially in for professionals, I mean, abroad, everywhere, as well as in India, that since these procedures are irreversible, that we take informed consent and that we have a GD certification. The gender dysphoria certificate ensures that the person is not doing this because he or she is mentally imbalanced or is under the influence of his peers, or that it's a temporary solution. Quite a few people go through various changes of gender identity. So we call them as gender fluid. And we want to be sure that a person who opts for gender affirming hormone therapy or surgery should be assessed for mental fitness. Um, so I have had discussions with my colleagues regarding this, and the idea is that by talking to psychiatrists and the gender dysphoria certificate essentially ensures that the person knows his or her mind and is aware of what it means to be transgender. Many a time, there is a lot of confusion in the person themselves. We see patients who come to us and tell us that they are transgender, but when we talk to them, we probe and we discuss further, it turns out that the person is actually homosexual or is bisexual, and it cross dresses only because it gets him or her, I mean, him attention. So the gender dysphoria certificate, in that sense, is I think, according to me, it's a good tool to clarify that the person is sure about what it means to be transgender. And as regards to the tussle, I'm not really involved with the legal side of things. The district magistrate can give the certificate based on what do I say, on a GD certificate. That is all that I know for now. I do not know any other way in which they can get this, or if they can get it. It is true that they have been insisting, and rightly so. I feel, for example, that if you're an adult and you say that you feel a particular way, you should not have to be assessed by a mental health professional. Um, but the thing is, we see a lot of young people who themselves are very confused about their gender identities, and we want to be 100% sure before they take a step that is very much irreversible.
Thank you, ma'am.
Yeah, I hope that answers your question.
Yes, ma'am.
Yeah. Was it very technical, too much of medical jargon? I try to keep it very basic and simple, but it still involves the use of quite a few technical terms. So I hope if any of you requires clarification, you can just write into me. I can try to explain it in a more simple manner if it was unclear.
Yes, Rajiv, you can ask question.
Yes, ma'am. So my question is that, so when we talk of gender affirmation surgery, so earlier it was used to refer to as sex change operation.
Yeah.
So I wanted to ask about like how did the terminology like shifted? I mean I can understand that it's more affirmative in that sense, but what were the changes that went beyond it, went for this shift in terminology from sex change towards gender affirmation?
Okay, that's an interesting question, Rajiv. The terms are constantly evolving. They are constantly evolving. It was first called HRT. A lot of doctors, for example, I'm just saying, call it HRT, which is hormone replacement therapy, until it was pointed out that you're not replacing hormones, but you are essentially giving the person the hormones that enable him or her to align their internal self with their external self. So, in that sense, it's gender affirming, it's not replacing. Similarly, sex change operations were previously called as SRS surgery. In fact, a lot of doctors and even people will refer to it as sex reassignment surgery. This is again, gender right activists and human rights activists who then made a very clear point saying that, it is not that you're reassigning the sex. The sex is always what the person feels inside. What you're doing is essentially just doing surgery that ensures that the external appearance matches the sex that you're doing. You're not reassigning it. You're just making sure that the two sides, or the two external and the internal parts of your identity and your expression are matching. So, in that sense, they pointed out that when you talk about sex change or sex reassignment, you are missing the entire point of gender dysphoria. The point is that the person feels like a woman or like a man inside. And you're not changing the sex, you're just helping that person through hormones and through surgery to better align the external characteristics. So this then came across as a more trans-friendly, trans-sensitive, and the entire, how do I say, a more appropriate description of the process. So I normally, I mean, when we joined, and we also, 10 years ago, I used to call it SRS as well, or HRT. But I personally also feel that this is a more accurate description of what we are trying to do with this procedure. So it is essentially gender affirming. We're not trying to change. It is not that a man gets up one day and says, "Hey, I want to be a woman and I want to change." No, the person has always felt like a woman inside, um, and is therefore opting for that surgery. So it's gender affirming surgery in that chain. This has all happened. The terminologies have all changed over the past 4 5 years. And as it's usual, what happens is that it trickles down from the West. So, for example, we always refer to WPATH guidelines, which is the World Professional Health. WPATH is World Professional Association for Transgender Health, and they are the ones who actually come up with these terms. So I have put this the website reference in the last slide. And if you have to read about the latest advances in transgender health and changes in transgender health terminology, WPATH is a very good place to start.
Thank you, ma'am.
Okay.
Dr. Kanchan, I have one question. Since you are in this profession from last so many years, do you see that there is any awareness, the level of awareness has increased among this community with
I
regard to
think
treatment?
um, about level of awareness regarding.
Treatment terms and the confusion, as you said, that even the medical professionals do, they do make sometimes they get confused, right,
Yeah.
for small things. So do you see that because when they go back and they share the same experience, somewhere do you feel that the level of awareness is building among the community?
So that's a good question. I think it is. Uh, there should be actually a study on this, but the rise of social media over the past 5 years has increased the level of awareness exponentially within the community. This is actually what I see is in the urban areas, in metro towns, in urban areas. All of them are equipped with smartphones, and the more literate ones, I would say education has a huge impact on their level of awareness. But I see almost everyone aware about the fact that, okay, there are certain surgeries that it is possible, for example, to have gender affirming hormone treatment or surgeries. What lacks actually is um, the desire to educate themselves. So there is a huge how do I say this, a disparity. When you notice that people who come from rural areas who don't have access to information uh, really find themselves handicapped. And for them, coming to a city and interacting with peers or with support groups, or with support groups who are undergoing gender transition processes, or just being in being aware that there are people like us out there, for them that is very empowering. And it contributes to their confidence, or it contributes to their level of awareness to a great extent. So there is a huge rural urban divide, but also because of social media, um, I see patients, for example, who come to us and say, "This is the kind of surgery I want, or this is the kind of treatment I want. What do you think is going to happen to me about, post surgery?" I have patients now discussing about sexual health. Would I be able to derive sexual pleasure after these surgeries? So there is the more educated, I would say, the ones who've done their graduation and are able to read up on the internet, are more aware. Um, the ones that come from the Hijra community, all of them are not so aware, but are definitely interested about knowing more. And once they understand, they are also interested in complying with the WPATH guidelines regarding provision of transgender healthcare. So when we explain to them, most of them agree, see the logic, and at least agree in person. So yes, that there has been a change. Now coming to healthcare professionals, I have not really, other than, I only interact with my cohort, and all of us are a network of doctors who are interested in LGBTQI health. But I come from a professional, a family of doctors, and I have not seen any awareness there, or any change of awareness there. There is still the same hesitancy, uncertainty, and reluctance to treat transgender patients. Um, One specialty that is comfortable with treating transgender patients is our dermatologists, because a lot of transgender women go to them for laser hair removal. So I would say it differs. Endocrinologists and dermatologists are comfortable. What is really lacking are primary care physicians, general physicians, who are comfortable with treating transgender patients for general health, for mental health, or gender affirming treatment.
Thank you. And another question, in the government hospitals, I don't know about the private hospitals. I have not seen any different ward for
Yeah.
transgender people, and just wanted to know that if any such patient comes to the government hospital, I mean, is there enough awareness among the staff who handle the case and who first registers the case, so that their level of comfort will definitely be better compared to, okay, yes, if nobody has any idea what he's talking or she is talking or they are talking, right? And then it is much more fear among them that where I am, they have no idea, I have to start everything from scratch, from zero.
Hmm. So, from what I hear from my patients, government hospitals are not sensitized. Healthcare professionals, healthcare workers there are not sensitized towards trans health issues. They are allotted beds in wards depending on what the resident doctor identifies the patient as. So there is a great deal of discomfort, which is why most transgender people actually end up paying double, but go to a small private hospital where they can be assured of privacy or have the freedom to use a toilet of their choice. Obviously, in public, in multi-specialty hospitals, if they go, they still don't have that freedom and are told to actually then go into a male restroom, for example. There are a lot of transgender activists there who are there for made requests and have pointed out that under the Transgender Protection Act, they are entitled to beds, to gender neutral toilets, and should not be refused admission on the basis of these on the basis of these infrastructure lack of infrastructural facilities. So I have read, but I'm not sure. The government has ordered that there should be a gender neutral or a trans friendly ward in every district hospital, at least. In every district hospital, like the. So I think steps towards that end have already started.
Okay, that's
It
good.
will, however, take some time because this community basically operates word of mouth. So we are essentially trying to encourage them to go to government hospitals, or we're trying to encourage um, the authorities in government hospitals to sensitize healthcare, workers as well, uh, to trans issues, so that they are able to better cater to them, and so they would feel more comfortable there.
Thank you. I hope this will be there soon, because I am also trying to get somebody from the law enforcement department, from the police department, so that we will have an idea about that how much information do they have, what are the ways that they handle these cases, right? Because it is very very important that they should also have information about this particular community, because whenever there is any raid, which is the first step, right? If there is any raid in the gay bars, so how and where do they keep? So I mean, whether the staff at the ground level have any information about which person to put in which cell, and the same as the medical ward, that which particular ward they should be admitted to, right?
Hmm.
So at the very primary level, I think these are the things that we are still lacking.
Yes, that is true.
uh, any more questions?
Excuse me, ma'am.
Yes, Runis.
Runcy Matthew, ma'am. Runcy.
Nancy Matthew, yes, please.
Runcy, ma'am. Yeah,
Nancy,
Rancy, yeah.
Nancy Matthew, yes, please go ahead.
ma'am. My PhD area is related to LGBTQ rights. I'm a law student. I'm a research scholar in law. I'm from Cochin. And my question is, would you ever feel like people who belong to transgender community who are facing some intersectional discrimination like caste discrimination
Mhm.
find it difficult to access health rights compared to others? Did you have any kind of feelings like that?
Oh, that's a very interesting question. In fact, we observed, or I have seen a couple of people who, for example, pointed out that all the trans leaders, if you look at trans activists, and this is a person coming from the intersection about caste and gender, who basically stressed that if you look at trans activists, or if you look at trans activists who have a voice, these tend to be upper caste, Brahmin, well educated transgender activists. And the fact that even when it comes to accessing healthcare services, it is the so called Savarna trans people with privilege who are able to access, who are able to articulate their transition journeys or their frustrations, and therefore receive more attention, and are even given more power, whether they as spokespersons of their communities, or whether it be as peer leaders in their in the NGOs that they work with. But we have observed, or rather they have observed, it is not my lived reality, and it is their lived reality. So this is something that has come across, that transgender people from how do I say, from lower caste, from Dalit backgrounds, have even a bigger struggle, not just to be accepted in their community, but to even make themselves, how do I say, for their presence and for their right to exist. So, if you want and if you're interested, I would be very happy to connect you with somebody who works on these intersectional areas of caste and gender. I do know a couple of activists who are very outspoken about this and are trying to highlight the fact that transgender and LGBTQIA community from lower castes have even more of a struggle in marking their presence.
That would be really helpful and grateful for me. Thank you so much,
Ransi, if
ma'am.
you could just share your email ID, or should I just, how do we go about this? I would love to connect you with those people. They have very interesting points of view.
Oh, can you share share your email ID in the chat box, or
Yeah, I can
I,
do that actually. I wanted to also, because if in case, you wish to ask something which is regarding this issue, you can also write to me at this email ID.
Sure, ma'am. Sure.
Yeah.
Thank you so much, ma'am. Thank you so much. Means a lot to me.
Yeah. You're welcome.
Any more questions?
But it's actually very interesting, Nunsi. I would just like to say this. Most of the people who have actually gone through the whole gamut of hormone treatment and gender affirming surgery, including facial feminization surgeries, these are the people who are actually the spokesperson of the communities. And that they have reached that level because maybe they came from a better socio-economic status, they came from a better educated background, and were able to leverage their privilege into becoming a spokesperson for the trans community. People come from rural areas who've had to work with these disadvantages of geography, of caste, of of class. Um, are left fighting on so many fronts that their health issues become even more acute. They observe and they see what is happening. Um, they are able to comment on it, but they have to fight harder to get to a level where they can make themselves heard. And we do have now organizations who actually focus on intersectionality and try to ensure this, but sexual minorities as well, who are also caste minorities or religious minorities, have even a tougher path in front of them, I would say, and require even more support, social support, in that sense.
And having a
I
social
understood, ma'am.
support, I
Thank you.
think it helps them building a confidence to carry their self in the society much more comfortably and confidently.
That is true. You would see a very distinct and marked confidence once the transition, or once they start with the process of transition. And it is, as a doctor, I would say it is the most affirming thing to see somebody who's been so distressed and conflicted to walk into your clinic, and with a radiant smile on their face. Because they are finally out with it and have started the process of gender affirmative treatment, and it has a huge effect on their self-esteem, on their confidence, on their mental health issues. The only issue where one of the most important things that I have seen that matters to the transgender community is love and acceptance. I mean, I would really like to end with this, because in the sense, if there's anything that matters to the community, it is being loved and accepted, not by the society. I mean, not just by society, but their parents, their siblings, their relatives, who are often the most harsh critics of their choice to live their gender identity. And the gut wrenching decision that most of them have had to make at the age of, say, 13, 14, or 15, to leave their families in order to be have the freedom to live a certain way, and the pain that it causes them to not to find themselves rejected time and over again, is something that contributes to a lot of the comorbidities and the mental health issues that you see in the transgender community. What is also most important, as a doctor, I feel, is sensitizing the teachers, and at the age of, when they're instructing children between 7 standards, say 5th standard to 10th standard, because this is the most tender age, um, where they are most sensitive, and they often drop out of school, and that leads to a lifetime of missed opportunities, and to have a good income, or to build yourself professionally. So sensitizing adolescent psychiatrists, sensitizing your local corner physician, who is the first doctor that the parents talk to, and your school counselors or your school teachers would really contribute towards more acceptance of trans health, of the transgender condition of LGBTQI community. And at that age, if they're addressed and they're taken care of and they are encouraged, then the outcomes that we're seeing, I think, will change quite a bit. As young adults, if you give them opportunities and acceptance, the whole life pattern changes. So that is my take as a physician.
Absolutely, you're absolutely right, because I feel the same. That my daughter, when we were in US, so she had this gender education right from grade 3.
Okay.
So she was never, surprised to see anybody carrying the way they want to carry. But it happened only in India when she came here back to India and she saw transgender standing on the signals and asking for money and clapping and all. So that is what, and when she asked questions to us, that why it
Mm.
is so. So
Yeah.
I think that gender education, imparting gender education at the school level, right from grade 4 or 5, will be of great help. Children from the beginning will be able to understand and accept, as you said, love and acceptance. I think these are the basic necessities for any human being.
That is true. Yeah.
That is the only way I think we can change the society. So first of all, Dr. Kanchan, I would like to thank you for the work that you are doing for the community, and especially this LGBTQIA community, and for the valuable information that you have shared today at this platform. Now I will request Saloni to give vote of thanks on behalf of all of us. Over to you, Saloni.
Yes, thank you, ma'am, and a very good evening to everyone present here. I am Saloni Kasayakar, a second year BLLB student at Shankar Rao Savan Law College, Pune. And on the behalf of the entire Marathwada Mitra Mandal and the organizers of this certificate course, I extend my heartfelt gratitude to you, Dr. Kanchan, and I appreciate your remarkable presence and making this session a really wonderful experience for all of us. I hope that we would have many more sessions like this with you in the coming times. And furthermore, I would also like to thank Dr. Renu Naidu ma'am and Shivani Jadhav ma'am for letting me do the honor of vote of thanks today. Last but not the least, I would appreciate all the participants over here for being supportive and cooperative throughout the session. And without you, it would have not been able to be and make this session really collaborative and interactive. So, thank you so much, everyone, and have a great time ahead.
Thank you so much, Saloni. So now the session is over for today, and I'm looking forward, Dr. Kanchan Pavar, to have you for some physical session, not only for the certificate course related, but I think for my students, for whether it is LLM students, because even the law fraternity and these students who are doing law, even they need to know and learn a lot about the healthcare,
I
especially
agree.
who are working in this particular for this particular community. Thank you very much.
Thank you.
Have a
I
great
would have
evening.
also enjoyed a actual physical session because my sessions are then we can make them more interactive. This was very one way, so I hope we can get back to the time when we can actually do this in person. And
Surely.
I'd love to thank you for this opportunity to be able to interact with all these bright young students. And let's hope that we continue this. I would love to contribute
Thank
anyway
you
I
so
can.
much, and all the best for the work you are doing. Thank you.
Thank you.
Yeah.